The video series Better Disease Management was developed by the Georgia and Oklahoma Academies of Family Physicians as a part of the Go Diabetes Initiative. The Better Disease Management series consists of 7 video vignettes, each outlining best practices in the care of diabetic patients. Please proceed to the registration page for more information on the approved number of prescribed credits for this activity as assigned by the American Academy of Family Physicians and AMA PRA Category 1 credit as assigned by the Georgia Academy of Family Physicians. Upon completion of each video vignette, please return to the Resources video page on the Go Diabetes website to complete the activity evaluation and earn your CME. This activity is supported in part by an educational grant from Sanofi Aventis. We thank you for participating in this online activity and hope that it serves as a valuable educational tool.
This is a board question, or it might be a SAM question. So go ahead and start answering these questions. Which of the following medications can cause high blood sugar? Nicotinic acid, otherwise known as niacin. Clozapine, an antipsychotic. Prednisone, you all know what that is. All the above. All right. 18 responses. Okay, so nobody picked nicotinic acid. Now we will talk. This will show up later. Just because niacin can cause that, it's a little bit like thiazide diuretics. Thiazide diuretics might raise blood sugar just a little bit. Doesn't mean you shouldn't use it. And the reason I say that is because it's been shown to reduce strokes and heart attacks. Anything that can reduce strokes and heart attacks is worthy of consideration. And nicotinic acid is somewhat similar. I'm not saying that you should use it first line for everybody, but it is something that I wouldn't necessarily put on your do not use list. Which of the following lipid-lowering agents can worsen glycemic control? Cholesterol, Zetia, Gemfibrozil, nicotinic acid, or Lipitor? I didn't give you all enough time on that one, but that one we just answered. Okay, and this one, I wish there was this is a great question that's off of, I think this was off of a SAM. A SAM is something that you, what is it, what is a assessment module? Self-assessment module, yeah. These are endocrinopathies that are associated with diabetes, include which of the following? And so basically with these, you've got to know what the hormone problem is, and you've got to know if that hormone raises blood sugar. Okay, so Cushing's disease, what's the hormone? Cortisol. Okay, acromegaly, growth hormone. Okay, pheochromocytoma, something we all heard about, never seen. What's the hormone? It's catecholamines. Okay, hyperparathyroidism. Parathyroid hormone, okay, and glucagonoma, glucagon, okay. All right, so we got the 5 hormones. Now, which of those raise blood sugar? Cortisol. What about B? Does growth hormone raise? All right, so we got a lot of people saying yes for B. What about catecholamines? Do catecholamines raise blood sugar? C. PTH? No. Glucagonoma? Yeah. So A, B, C, and E are the right answers there. Any questions about that one? I think that's a good question, but it's a pretty hard one though too. The hard one there, I think, is the catecholamines. You know, you think, the catecholamines raise blood sugar. You know PTH doesn't. You know glucagon does. You know cortisol does. Okay. Mark all the options that are true regarding diabetes screening according to the current American Diabetes Association guidelines. All right, the first one is to get yourself to know what's the recommended screening test. It says a 2-hour glucose challenge test is the recommended screen. True or false? It's false. Why is it false? It's inconvenient, unlikely to happen, less likely to happen. Usually what happens is you get somebody and you're like, you know what, their blood sugar was 127, kind of high. And you think, I need to bring them back in. And you know, when you bring them back in, they may or may not come back to do it. And it's a burden on the patient to spend, you know, 2 or 3 hours at the doctor's office getting their lab done. And so for that reason, and it's more expensive, okay? And so for that reason, it's not that it's not a good test as far as sensitivity and specificity and that kind of thing. It's just there's other ways that, and it probably is a little more sensitive. Dustin, I think, is going to talk about that a little bit later, that it is a little bit more sensitive than just checking fasting glucoses, but not necessarily the recommended screen. What about B? Screening at 3-year intervals is recommended in individuals with a BMI greater than 25 beginning at age 45. You're going to be screening a whole lot of people, but that's actually true. Now, and this is according to the ADA, okay? This is not United States Preventive Services Task Force. So there's a difference there as far as what kind of screening criteria that they're going to use. But according to the ADA, they would say yes on B. C, screening should be considered in all women who have delivered a baby weighing over 9 pounds. That's true. What about D? Community screening for diabetes is felt to be valuable and cost effective. So in other words, you know, hey, we're having a health fair. Come on down here and get your blood, you know. Cost effective and valuable. Not so much, you know, it's not something that you just bring everybody in and do a massive screening. And the reason for that, the questions to ask about diabetes, it's so easy to identify people who are at risk. You can ask about 3 or 4 questions, you can identify the people that need to be screened versus saying taking on the massive, you know, population as a whole. What about E? Measurement of hemoglobin A1C has no role in screening for diabetes. That's false. Now, you guys are smart. You know, a year ago, this answer, some people would have said that the answer is true, and the ADA changed that. They've been trying to standardize A1C measurements for a period of time, and now there's enough consensus that these are reproducible. You know, an A1C in my lab, which might be 6.2, might be 6.4 at your lab, and so there's a lot more standardization with A1Cs where it's felt like that it is a reasonable way to go ahead and screen. I use it more for confirmation. You know, if I get somebody with a glucose that doesn't necessarily, they come in, you get a random chemistry because they're on blood pressure medicine once a year and you check them, you know, and it's high, then I'll have them add an A1C onto that lab specimen for diagnosis, which is the best thing I've found. Or if somebody says, yeah, I've had a high blood sugar before, then instead of ordering an A1 or a BMP, I might just get an A1C. But you'll diagnose a lot of people. All right, any questions about those? All right, I don't want to insult your intelligence with this one. You guys know that this is like USMLE, you know, 1 or 2 kind of stuff. 3 conditions in the differential diagnosis of a high anti-Mgmt metabolic acidosis. Mud piles, you know the mnemonic, right? Methanol, uremia, DKA, paraldehyde. What's I? What? Isoniazid, all right. Lactic acid, ethanol or ethylene glycol, and salicylates. So any of those conditions can cause a high, or there's other things too, like starvation, ketosis can cause that.